And I will ask for any questions. If you have any questions, I think there are a lot of our colleagues who will sit for the exam for the first time, and they want to ask about the exam. So Dr. Ahmed Reda, I know you have some questions about the exam. So what are the questions that you have about the exam? Okay, so any questions about the exam, especially for our colleagues who will sit for the exam for the first time? Okay, so let us start, and feel free if you have any questions at any time, you can ask, because the most important is to be familiar with the exam, to know how it goes, what are the pitfalls, what are the problems during the exam, in order to be as if you have sat the exam before. So very important to know how it goes. I will start something which is very new. I will start with clinical examination and eliciting signs. So our session today will be how to examine the patient, how to elicit signs, how to present your findings to the examiner. If you know how to examine the patient and what are the signs that you have collected, and all this will be done in your head. You will get, even in long cases, it's not recommended at all to use a paper or to write or to take notes. No time for this. The most important to get all the information while you are taking history, and how to collect this and make presentation ready in your brain in order to present your findings to the examiner, to reach a differential diagnosis and a final diagnosis, to know how to investigate this case and how to manage this case. Any scenario starts with symptom. The presenting complaint or the main complaint is a symptom for long cases. So the presenting complaint is the key for reaching a differential diagnosis. By differential diagnosis, you will reach a final diagnosis. In the Irish exam, the final diagnosis is important because you will not have any chance to examine the patient. You will find no signs. So you should reach a final diagnosis while you are taking history. This is very important point for Irish exam. Okay. So for clinical examination, there are some cases like these cases. These are spot diagnosis. You have some cases which are spot diagnosis. The most important to catch these cases while you are examining the patient. What is this?
Myotonia dystrophica.
Myotonia dystrophica.
Yes, this is myotonia dystrophica. This is myotonic facies, which is very characteristic. The baldness, the ptosis, drooping of the upper eyelids, the temporalis wasting, the apathetic face. There is no impression, there is no wrinkles, and there is very clear that this is the myotonia dystrophica. This is a spot diagnosis. Myxomatous or turbid facies, this is very characteristic of the hypothyroidism, and hypothyroidism is very common in the exam. They bring you a case of hypothyroidism in endocrinology. This is a spot diagnosis. You will find that there is loss of the outer third of the eye brow, and you will find there is puffiness of the face and the periorbital swelling, boogie of the eyelids, and you will find xanthelasmas because of hyperlipidemia. So this is one of the most important characteristics of the hypothyroidism. And for hypothyroidism, I have very important note you should know in the exam. Hypothyroidism, they bring you a case of thyroid swelling. This is very common in the Irish exam. They bring you a case of thyroid swelling. In reality, this case is sometimes it's Hashimoto's disease with hypothyroidism and polynodular goiter, but they want you to be aware about the thyroid tumors, medullary thyroid carcinoma, which is very important for the exam because actually medullary thyroid carcinoma, this is related to MEN2. So they want you to be aware about the MEN2 syndrome. They will tell you this thyroid swelling for 1 or 2 months, while this patient has thyroid swelling for many years. And it's Hashimoto's disease. Why they do this? Because actually you should be cancer-oriented. You should put into the differential diagnosis the possibility of cancer. Cancer thyroid is a killer because medullary thyroid tumor is operable. And usually if discovered early, it will have no metastasis. But the most important to consider hypercalcemia or hyperparathyroidism and pheochromocytoma, which are killers, and you should never neglect this whenever you find thyroid swelling. This is thyrotoxic phases. Thyrotoxic phases you should be familiar with, even in your clinical practice. Those patients should be managed very early. Graves' disease should be diagnosed and managed before this stage. So you should consider hyperthyroidism or thyrotoxicosis or these thyrotoxic phases. Whenever you see these phases, you know this is Graves' disease, or sometimes it's related to hyperthyroidism. So hyperthyroidism, Graves' disease, it's usually associated with eye changes. The exophthalmos or proptosis is the main clinical feature in case of thyrotoxicosis. So thyrotoxicosis, it's very important for the exam. And sometimes if you don't examine the eyes during the examination, you should be aware of all the important manifestations about hyperthyroidism. Hyperthyroidism, it's related to Graves' disease. And the Graves' disease is autoimmune disease. So Graves' disease is one of the important association with other autoimmune diseases, or sometimes it's associated with other diseases. So hyperthyroidism or thyrotoxicosis is the spot diagnosis. This is the thyrotoxic phases, and you should know about the acrobatchy hands. It's like clubbing of the fingers. It's very similar, but it's related to hyperthyroidism. You should know about tachycardia, high blood pressure, myositis. Sometimes it's related to loss of weight. Even the patient is eating more. There is loss of weight, there is tremors, there is insomnia, there is irritability, nervousness. So all the manifestations of hyperthyroidism, and it's very important case in long cases. For the exam, they sometimes bring thyrotoxicosis as long case. So thyrotoxicosis, these are the characteristic phases. This is Cushingoid or Cushing syndrome. Cushing syndrome is very important, and there was some question about how to differentiate between Cushing syndrome and acromegaly. Acromegaly is a totally different phases, very different and very important to know what are the characteristics and what are the findings and the signs that you elicit in acromegaly phases and in Cushing syndrome. Cushing or Cushingoid syndrome. The most common cause is iatrogenic. People who has some autoimmune disease, rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, allergy, whatever cause of use for long-term corticosteroids will lead to Cushingoid syndrome and Cushingoid fascias. Cushingoid fascias, it's rounded face. It's called moon face. And you'll find buffalo hump, the interscapular region will be, there will be interscapular fat bed, there is fat, and there will be striae, there will be central obesity. So it's very easy to differentiate between this. And the plethoric face, you will find there is too much blood and there is redness of the skin of the face. This is Cushingoid fascias. So the rounded plethoric face giving the rise to moon face, and there is buffalo hump, there is hirsutism, there is acne, there is striae, there is central obesity, interscapular bed. All these are very characteristic of Cushingoid disease, which is a spot diagnosis, and it's very common in the exam. You should know this. This is the Cushingoid faces. You will find there is hirsutism and acne. So this is very different from acromegaly. Acromegaly, there will be bossing of the frontal bone, will be elongated. The face will be elongated, enlarged nose, enlarged lips, enlarged ears. There is prognathism. There is protrusion of the lower jaw. There is macroglossia. And there is actually what is called the spade-shaped hands or acromegaly. Acromegaly means enlargement of the extremities, the hands and feet. So acromegaly is totally different. There is protrusion of the supraorbital ridge. This is acromegaly. So is it possible you can be confused between these Cushingoid fascias? Because one of our colleagues was asking about the difference or how to differentiate, or in one exam, somebody was confused between Cushing and between acromegaly. So acromegaly, there will be coarse facial features with prominent supraorbital ridge. The supraorbital ridge is prominent, and you should give the examiner the impression that you are examining from the side of the face for prominence of the supraorbital ridge, and you'll find there is increased wrinkling of the forehead. There is prognathism. There is very big nose, very big lips, very big ears. All the soft tissue will be enlarged and macroglossia. And you'll find usually there is skin tags on the neck, and you'll find sometimes there is proximal myopathy. And you should think about the carpal tunnel syndrome. You should think about cancer colon. You should think about a macroadenoma of the pituitary may lead to bitemporal hemanopia, may lead to headache, may lead to a lot of manifestations. So this patient is very rich in the exam, and the presentation will be variable, starting from headache and a lot of causes of headache. What are the causes of headache in this acromegaly? Anybody can tell?
Space occupying lesion of macroadenoma.
Yes. So I need causes.
Sir,
Yes.
and
Also
Cholextroma.
Obstructive sleep apnea, hypertension,
Okay.
and associated pheochromocytoma.
Yes. Associated pheochromocytoma. Do you think this patient will have pheochromocytoma?
Yes, is men one.
Men one. Men one is what?
No, sorry, no. Men two.
Okay.
It is
So-
pheochromocytoma in men two.
So
Yes.
what is in men two? What is in men one and what is in men two? What is the combination? Actually, this I love this to be interactive and to be like brainstorming. This will give you will end up after this session, with a lot of information. Better than discussing one case and scenario, I prefer to discuss different cases in order to gain the eliciting science skill, which is very important for the exam and for your clinical life. So what are the causes of headache in this patient?
Doctor, maybe due to hypercalcemia from
Hypercalcemia. Thank you very much, doctor. Thank you very much.
Sleep apnea.
Obstructive sleep apnea. Okay, so space occupying lesion, the presence of macroadenoma, this will lead to frontal headache, may be related to hypertension, may be related to obstructive sleep apnea, may be related to hypercalcemia. And hypercalcemia is very important in the exam because hypercalcemia may be presented by headache, may be presented by confusion, may be presented by constipation. They start with this scenario, this symptom, headache. Headache, whenever you see headache, think about hypercalcemia because sometimes in the exam and under stress, we don't think about hypercalcemia as a cause of headache. This exam-wise, headache, chronic headache, equal first hypercalcemia. Hypercalcemia is very important, and we have a package for hypercalcemia. You should ask all the questions related to hypercalcemia. May be presented with constipation, hematuria, renal colic. Sometimes it's related to polyuria, polydipsia, which we always think about diabetes and forget about hypercalcemia. Hypercalcemia, one of the causes of polyuria and polydipsia is hypercalcemia. These are the presentations of hypercalcemia. So hypercalcemia, the main presentation is headache. Headache. Whenever you have a scenario of headache, chronic headache, you should think about hypercalcemia and you should ask all the questions related to hypercalcemia. Headache, confusion, polyuria, polydipsia, constipation, renal stones. Sometimes it leads to renal colic or lead to hematuria. And constipation. Constipation, very easy scenario about constipation. You will start with constipation and you will end with multiple myeloma or sarcoidosis. Hypercalcemia, the causes of hypercalcemia, and may be part of MEN 1 or MEN 2. This is the differential diagnosis, the most important differential diagnosis of hypercalcemia. Sometimes metastasis, bone metastasis, destruction of bone and the release of calcium. Hypercalcemia may be a manifestation or presentation or a symptom of hypercalcemia related to malignancy. Sometimes it's paraneoplastic. Paraneoplastic, some tumors, especially the lung cancer or lung tumors, may secrete the parathyroid resembling peptide or protein. This is a separate from parathyroid hormone. This is, you should examine the patient. If you will do investigation, examine the patient for parathyroid resembling peptide. Parathyroid hormone may be normal. And this is paraneoplastic. You will end up with cancer, which is very important. Starting with headache, the scenario is headache or constipation or hematuria or renal colic or constipation, and you will end up with polyuria and polydipsia, and you will end up with cancer. And that's why they bring these cases, very important scenarios. Headache, polyuria, polydipsia, constipation, renal colic, hypercalcemia. What are the causes? You think about malignancy. Malignancy. They bring this case especially to know if you are malignancy oriented or not. These are very common cases in the exam, very simple scenarios. Whenever you have constipation, you should be cancer oriented, cancer colon. And here, in this case of acromegaly, you should think about cancer colon. Cancer colon is a killer. And you should ask about any blood with a stool. The bowel works. Any blood with a stool. And the cancer colon is very important. It may be there. That's why colonoscopy is the most important investigation after investigating the disease itself. After investigating acromegaly, you should think about cancer colon. Why? Because it may send the metastasis to the brain, to the meninges, to the brain, and may cause headache. One of the causes of headache in acromegaly, secondaries or metastasis from cancer colon. Because here, the growth hormone will stimulate any abnormal tissue. If there is any polyp with precancerous character, it may develop into cancer colon. So cancer colon is very important, and whenever you see these phases, you should think about obstructive sleep apnea, you should think about carpal tunnel syndrome, you should think about proximal myopathy, you should think about hypertension, you should think about diabetes, you should think about all the hormones secreted by the pituitary gland. There will be hypogonadism, because the tumor will cause compression on the stalk of the pituitary and may cause hypogonadism. FSH and LH will be decreased, hypogonadotrophic hypogonadism. And there will be most probably hyperprolactinemia, which is one of the most important causes of amenorrhea in menstruating ladies, and will lead to not gynecomastia in males, but it will lead to loss of libido, loss of sexual drive, and loss of sexual ability, impotence, erectile dysfunction. So this is important, and you should consider this whenever you see this patient in the exam. It's a spot diagnosis. We should confirm the diagnosis, and you will never miss or mix this patient with any other diagnosis. There is no other diagnosis like these phases. These phases are very important. One of the very important resemblance is Paget disease. Paget disease of the bone may lead to bossing of the bone and enlargement of the bone, but it will lead to bowing of the lower limbs and will lead to deformity, which is asymmetric. It will be asymmetrical deformity of the bones. Here in acromegaly, you will find it's all very regular. You will find bossing of the frontal bone, prognathism. You will find there is protrusion or prominent supraorbital ridges. You will find macroglossia. You will find enlargement of the lips, enlargement of the tongue, enlargement of the nose, ears, very characteristic. You will never miss this case in the exam because it's one of the most common cases in the exam. Acromegaly, I think it's very common, and there is one patient in Jeddah. His name is Nabil. This Nabil has acromegaly, and he's a chronic patient in the exam. You will find this patient acromegaly. You should think about bitemporal hemanopia. You should think about headache. You should think about cancer colon. As I said, this is training. Train yourself on snapshot. You see the patient, a spot diagnosis, you should, at the same moment, you make a comprehensive picture of all the important symptoms and signs of this patient and the important complications and associations. What are the important complications? Heart failure, hypertension, diabetes, peripheral neuropathy, renal failure. You may find hepatomegaly, you may find cancer, you may find all these are complications and associations of this disease. So acromegaly in itself is easy diagnosis. You should confirm the diagnosis. You should ask about the common complications of this disease, and you should ask about the associations, MEN1 Men 1 hypercalcemia and pancreatic tumors. Pancreatic tumors may be acid releasing, gastrinoma, VIPoma, vasoactive intestinal peptides, or sometimes gastrinoma, acid secreting, which will lead to peptic ulcer resistant to BBIs. So you should ask in this patient about the GIT symptoms. Any acidity, you should ask about the medications. Show me your medication list, because you will find BBIs, you will find antacids, you will find a lot of medication, even over-counter medications for acidity. This patient is resistant to BBIs. Glucagonoma, one of the pancreatic tumors which may be associated and one of the causes of hyperglycemia. Glucagonoma. And you should think about other complications like carpal tunnel syndrome, obstructive sleep apnea. You should think about the sweating, about too much perspiration, about skin tags, about obstructive sleep apnea, about cancer pool. One shot. Whenever you see this patient, train yourself to think about the most important points, to ask while you are taking history, to examine bitemporal hemianopy, visual field. And visual field, it's the easiest test to be done in the exam. Red hat bin or any bin, and you move the bin in front of the patient, you will find bitemporal hemianopy, loss of peripheral vision. How to ask about bumping into the furniture, inability to see the sides of the street or the sides of the room. The patient will have just central vision, no peripheral vision, bitemporal hemianopy. And there will be headaches, there will be diabetes, there will be hypertension, there will be cancer, there will be obstructive sleep apnea. So you ask about all the manifestations of acromegaly, all the complications and association. Men 1. These are the associations of acromegaly. Secretion of prolactin, you should think about prolactin, and you should know that prolactin will not cause gynecomastia. Gynecomastia, it's caused by estrogen in males. So prolactinemia, hyperprolactinemia, or prolactin will cause galactorrhea, secretion from the breast, secretion from the nipples, and will lead to amenorrhea in females, and in males will lead to loss of libido, impotence, as also as what it's caused by the lack of luteinizing hormone, and FSH, follicular stimulating hormone, will be deficient due to compression of the macroadenoma of the pituitary over the stalk and the affection of the other hormones. There may be hypothyroidism, and there may be hypoadrenalism, because all the hormones of the pituitary will be affected except for growth hormone and prolactin. Gynecomastia you will find in case of liver cell failure. The liver is not able to destruct, and sometimes it's to destruct the estrogen secreted by the adrenal gland, and this will lead to gynecomastia in males. Liver cell failure. Gynecomastia is a manifestation of liver cell failure, but not a manifestation or result of hyperprolactinemia. So hyperprolactinemia, yes, doctor.
Sir, here hypercalcemia because of man 1 syndrome, like because of the hyperparathyroidism, right?
Hyperparathyroidism, yes, hyperparathyroidism, hypercalcemia. And hypercalcemia, it has a package.
Thank you,
It's
sir.
headache, confusion, depression, 3 in the head. There will be thirst or polydipsia and polyuria. There will be constipation, there will be renal stones, calcium stones, renal colic or hematuria. These are the manifestations, the package, the questions that you should ask in order to rule out or rule in hypercalcemia in any case. Even you are suspecting a presentation, the case, please take history and examine this patient with constipation. And you find that this package is positive, you know that this case is hypercalcemia. What are the causes of hypercalcemia? Primary hyperparathyroidism. Men 1, men 2, hypercalcemia. Sarcoidosis, hypercalcemia. Release of calcium from the bone because of metastasis, or primary bone tumor, malignancy, multiple myeloma. So this is the differential diagnosis of hypercalcemia or the causes of hypercalcemia. The causes of hypercalcemia. Whenever you find this case, you should ask about men 1 hypercalcemia and pancreatic tumors. Ask about the stomach. Zollinger-Ellison syndrome, VIPoma, vasoactive intestinal peptide, VIPoma, gastrinoma. These are tumors which will secrete or cause increase in the acidity of the stomach and diarrhea. Although the commonest presentation in acromegaly is constipation. But the presence of diarrhea, you should be suspicious. With the presence of blood with the stool, you should be more suspicious about cancer colon. So GIT symptoms in this case are critical. You should ask about all the manifestations of GIT. The acidity, the heartburn, the chest pain, the nausea, vomiting, dyspepsia, indigestion, bloating, irregular bowel habits, any change in the bowel habits, and you expect constipation or diarrhea. Diarrhea may be related to cancer, and if there is any blood, you should be more suspicious of cancer, or sometimes it's related to pancreatic tumors like gastrinoma, VIPoma, or Zollinger-Ellison syndrome. Or sometimes one of the causative or causes of hyperglycemia is glucagonoma or insulinoma. Insulinoma, the patient is gaining weight and the craving for sugar all the time, and there is increase in the body weight and attacks of hypoglycemia. Insulinoma. So this is the contrary to diabetes, which is the commonest association or a causative or the one of the presentations of acromegaly. You should think about whenever there is a change from hypercalcemia to hypoglycemia, from hyperglycemia or diabetes to hypoglycemia, you should think about insulinoma tumor, secreting insulin from the pancreas. Insulin-like growth factor is diabetogenic. This is the commonest in acromegaly, and we take it as screening for acromegaly. Insulin-like growth factor. 1. So this is very important. Whatever I'm telling you, it's sometimes it's a free talk. We talk just brainstorming. We are jumping from one issue to another issue, but this will help you to gain too much information exam-wise. So this information I'm telling you now, sometimes it looks like not organized or we are talking freely. I prefer that in order to gain as much as you can information before the exam. This is the exam. Presentations of acromegaly. What are the presentation? What do you think? What are the presentations of acromegaly? Whenever you go to the room and you find this Mr. Nabil, who is acromegaly, and you find these very characteristic faces, which will never be confused with any other diagnosis. Whenever you find this case, what do you expect? The examiner will tell you about the presenting symptom or the presentation of this patient, the complaint. What do you think? I need just suggestions. Brainstorm. Feel
Headache,
free. Unmute and tell yes, please.
headache,
Headache, yes.
joint
What?
pain, joint
What?
pain,
Joint pain, thank you very much. Osteoarthritis. Because of enlargement of the bone, there will be a narrowing of the space, and there will be sometimes even deposition of calcium on the cartilage, and this will lead to osteoarthritis, joint pain, back pain, narrowing of the canal because of, think about enlargement of the bones. Here there is no elongation of the bone. The bone will be broadened. Even sometimes it compresses the auditory nerve and causes loss of hearing loss, sensory, neural, hearing loss. Those patients, because of enlargement of the mastoid bone and compression on the meatus. So this may lead to compression on the auditory nerve. This may lead to loss of hearing. So enlargement of the bone, as general, will lead to narrowing of the spinal canal and may lead to compression on the spinal cord, the vertebral column. There will be compression, and there will be compression on the vertebrae. This may lead even to some manifestations of disc prolapse because actually of the compression, and sometimes there is degeneration of the cartilage, and there will be compression on the nerve roots. So this one of the presentation, back pain or joint pain. What else?
difficulty in sleeping,
Difficulty in sleeping, or we say obstructive sleep apnea. Yes, so obstructive sleep apnea is a diagnosis, but it will be presented by difficulty in sleeping or snoring, or sometimes day somnolence, or lack of concentration, or morning headache. Because actually, as I said, we should know the difference between different types of headache. If the headache in this patient is morning time headache, what is the diagnosis?
Masa.
Yes, obstructive sleep apnea. Obstructive sleep apnea. The headache will be in the morning, there will be somnolence, they will gain weight, gaining weight. Gaining weight. One of the presentation of this case in the exam, gaining weight. Do you agree?
true,
Yes, gaining weight. Too much enlargement of the bones and soft tissues. This patient will be gaining weight. What else?
Visual problem.
Sorry, I cannot hear. Please unmute and be active. Tell something.
Carpal tunnel.
Sir, are you asking for history or examination point?
I'm asking about the presentation. What are the possible scenarios in the exam for this patient of acromegaly? The symptoms that may be presented by the examiner in order to present this patient to you. The examiner will tell you, please examine this patient with what? Or take history and examine this patient in long case. In Irish exam, it may be is as short case. What else?
can present
Fatigue.
is rectal bleeding,
Increase
loss.
increase
Due to chronic.
shoes size and decrease increase fingers to
So change in
compensate
the ring, yes, a change in the ring
Yes,
size,
ring.
and the change in the shoes, and the change in the picture. Yes. What else?
maybe
rectal
hyperglycemic
Fatigue.
features including polyuria, polydipsia,
Yes,
polyphagia,
polyuria, polydipsia. Yes. What else?
excessive sweatings, It
Excessive
depends
sweating.
on
Yes, perspiration or hyperhidrosis. What else?
Hypertension, diabetic.
hypertension,
and
yes.
diabetes. Hypertension, they will never tell you examine or take history from this patient with hypertension or diabetes. They will tell you examine this patient with headache, so it's a symptom. It's not a diagnosis.
Hand pain due to carpal tunnel syndrome.
Carpal tunnel
Yes, sir.
syndrome. This is exactly what I was expecting to hear from you. So what is the presentation of carpal tunnel syndrome? What is the symptom of carpal?
Joint pain.
Sir, patient present with pain at night, which improve after shaking the hands.
Yes. So sometimes needles and pins in the hand, sometimes weakness, sometimes it's related to pain in the hands while doing sometimes daily work, and sometimes while writing, while using the hand or shaking hands. Yes, there will be pain, wasting of the muscles of the hands, weakness, pins and needles. I want you to be familiar with these symptoms, because here this patient may be presenting with carpal tunnel syndrome. Carpal tunnel syndrome is a diagnosis. It's not a presenting symptom. Don't expect the examiner will tell you, please examine this patient with carpal tunnel syndrome. He will tell you, please examine, but it's very important. While you're examining the patient, what he will do, Tinel test and Fallon test. Tinel test and Fallon test is very important in rheumatoid arthritis and in acromegaly. You should expect what other presentation. Weakness of the patient is unable to comb his hair or her hair, or to go upstairs or downstairs, or to bring something from high shelf. Proximal myopathy. Yes, proximal myopathy. Look at how many presentation in this case. How many presentation? And this you should be aware of.
Also.
What's that? Constipation or diarrhea or blood
Yes.
with stool.
Blood with stool.
Yes, sometimes hematuria. What is the cause of hematuria?
renal stone,
Renal
apart
stones,
from multiple
hypercalcemia,
calcemia.
polyuria and polydipsia may be related to diabetes, or hypercalcemia may be presented with confusion, depression, impotence, ED, erectile dysfunction, sexual dysfunction.
Knee pain.
Yes, secretions from the breast, hyperprolactinemia, fatigue and weakness. Do you agree? Fatigue and weakness. What is the possible cause of fatigue and weakness? The differential diagnosis of fatigue and weakness in this patient.
Cushing hypothyroidism.
No, Cushing. Where is Cushing here in this patient? What is the cause of Cushing? Addison, adrenocorticotropic hormone deficiency. Here, it's not Addison, I'm sorry, hypoadrenalism. Addison is autoimmune disease. It's not a cause of adrenocorticotropic hormone deficiency. In Addison, there will be more. It will lead to increased. But in hypoadrenalism, this is secondary to lack of adrenocorticotropic hormone. So there will be hypoadrenalism.
Hypogonadism.
Hypogonadism, yes. What else?
Obstructive sleep apnea lead to fatigue.
Obstructive sleep apnea, one of the causes of fatigue. What about secondary hypothyroidism? Do you agree?
Yes.
Yes.
Also,
Because of compression on the thyroid stimulating hormone will be deficient. This will be secondary. You expect whenever there is TSH is low, you expect that 3T4 will be high. You do TSH find low and 3T4 is low. What is the meaning of this? This is secondary hypothyroidism. The problem is in the pituitary. If you, for example, for any reason, you are doing TSH is low and the free T4 is low, this means the problem is in the pituitary. Do you agree? This is secondary hypothyroidism, not common in life, not common in practice. You will not find this case in practice. But whenever you find low TSH and low free T4, there is secondary hypothyroidism. The problem is in the thyroid, in the pituitary. If it is in the thyroid, you will find the problem is in the thyroid. You will find low TSH and high free T4. Graves or active nodule or any cause of hyperthyroidism. So this very rich case in the exam and very common in the exam and a lot of scenarios. You find all possible scenarios starting from headache to constipation or diarrhea or hematochezia. Stool is mixed with blood, or sometimes renal stones, sometimes renal colic, sometimes you will find there is hematuria, sometimes polyuria related to hypercalcemia, sometimes dry mouth related to diabetes or related to hypercalcemia, headache, 5 causes. What are the causes of headache in this patient? 5 causes. The space occupying lesion related to pituitary macroadenoma, hypertension, hypercalcemia, and I want you to promise me not to forget in your life hypercalcemia. Hypercalcemia is the commonest case in the exam because it's very rich and a lot of causes. One of the causes is MEN1 and MEN2, hypercalcemia. Examine this patient with headache and you find hypercalcemia related to multiple myeloma, related to sarcoidosis, related to malignant breast cancer, prostatic cancer with secondaries to the bone. Hypercalcemia, the main presentation, the main package. Here, the package, you know the package. Headache, confusion, depression. Sometimes you will find there is polyuria, polydipsia, renal stones, hematuria, constipation. This is the package for hypercalcemia, sometimes associated with some other GIT problems. Sometimes it's not constipation, it's diarrhea. What is the cause of diarrhea? Pancreatic tumor. Pancreatic tumor. Gastrinoma, Deiboma, Zollinger-Ellison syndrome. Diarrhea. And hyperacidity and heartburn and chest pain and all this, epigastric pain, all these are manifestations which are not relieved by PPRs and persistent or resistant peptic ulcer. Think about pancreas or glucagonome or insulinome. So sometimes you find diarrhea because of pancreatic tumors associated with MEN1, which is mainly pituitary tumor. Pituitary tumor may be any tumor. What is the most common? The acromegaly, growth hormone, and the prolactin. Prolactinoma and growth hormone. Sometimes some tumors may secrete, for example, thyroid stimulating hormone or adrenocorticotrophic hormone. So this will give manifestations of Cushing syndrome or Cushing disease because of pituitary, Cushing syndrome, any cause of increase in cortisol. Cushing syndrome. Cushing disease, it's related to pituitary. So macroadenoma secreting adrenocorticotrophic hormone will lead to high cortisol. Cushing disease, adrenocorticotrophic hormone. In case of primary, in the adrenal itself, it will lead to low adrenocorticotrophic hormone because of the negative feedback. So you should be prepared for the exam. Whatever I'm telling you now, nobody will tell you because actually this is how you think medicine. You think medicine. You get the spot diagnosis and you go for all the manifestations to confirm the disease, and you go for complications of the disease, and then you go for associations, and associations is very important term in many diseases. Autoimmune disease, you'll find association. In malignancy, you'll find association. What they love in the exam, MEN1, MEN2, and the apes. Autoimmune polyglandular syndrome, apes. Type 1 diabetes, Addison disease. Here it's Addison disease. Addison disease because it's autoimmune disease. It's polyendocrine, autoimmune polyendocrine syndrome. Addison disease and thyroid, autoimmune thyroid disease. Autoimmune thyroid disease. What are the autoimmune thyroid disease that you know?
Hashimoto's.
Hashimoto's and
Graves.
Graves. Yes, Graves. Whenever there is one autoimmune disease, think about the whole package. It's a family. So autoimmune diseases, the most important for the exam is apes. Autoimmune polyendocrine or polyglandular syndrome. Many forms, sometimes with candidiasis type 1 or type 2, but the most important for the exam sake or for the exam, we are not endocrinologists, so know about apes 2. apes 2, autoimmune polyendocrine or polyglandular syndrome. Thyroid autoimmune disease. You may find Graves or Hashimoto's. Addison disease, autoimmune, adrenal insufficiency. Addison disease is autoimmune. What are other causes of hypoadrenalism or hypo or adrenal insufficiency? What are other causes other than Addison disease? Tuberculosis,
Adrenal.
Antiphospholipid syndrome.
yes, if there is any ischemia and infarction of the gland, it's a vascular reason, yes. What else?
Meningococcal
HIV.
septicemia.
Yes, infection and the damage of the gland, yes, infection. What else?
Metastatic cancer.
Metastatic cancer and the damage of the gland, yes. What else?
Adrenalectomy.
Adrenalectomy. This is very important because actually in one point of time, they used to do adrenalectomy for obesity as treatment of obesity. So they remove the adrenal glands, or sometimes after MEN2, they remove the adrenals, phychromatocytoma, they remove the adrenals. So whenever they remove the adrenals, there will be hypoadrenalism as the main cause of panhypopituitarism. What is the main cause of panhypopituitarism?
Sheehan.
Sheehan syndrome. What else?
Pituitary surgery, removal of pituitary.
Yes. Hypophysectomy. Removal of the pituitary gland. This is the main cause after any tumor. Sometimes macroadenoma causing pressure, causing bitemporal hemanopia, prolactinoma, tumor like here in case of acromegaly, the only treatment is, or sometimes damage by radiotherapy. They damage the gland. If the patient is unfit for the surgery or failure of the surgery, they go damage the gland by radiotherapy. So this will lead to hypopituitarism. What are other causes? Infarction of the gland, absence of the gland.
Pituitary apoplexy.
Apoplexy, thank you very much. Acute cause of failure of the gland. Apoplexy. What else?
Infiltration by sarcoidosis.
Infiltration by tumors. Yes, sometimes it's related to vascular. So whenever you think about any differential diagnosis, think about surgical indication. This was case in one of the exams. They show me your medication list. He is taking all the replacement therapy for pituitary, pan-pituitary pituitarism. He's taking all the hormones, testosterone, taking euthyrox, he's taking cortisol, is taking all the replacement hormone. He didn't ask about surgical history. And this patient proved to have acromegaly, and he had hypophysectomy, removal of the pituitary gland, transsphenoidal hypophysectomy. And nobody think about the main cause, which is surgical removal of the gland. Surgical removal of the gland. The patient is started with the diagnosis of acromegaly. He went through investigation, which proved to have pituitary macroadenoma. He went through the surgery, transsphenoidal hypophysectomy, and ended up with hypopituitarism. So it's very important to think comprehensive whenever you have a case, especially in case of endocrinology. The differential diagnosis, whenever you are putting the differential diagnosis, put malignancy on the top of the list till proved otherwise. Malignancy, how you ask about malignancy? In exam-wise, there is history of malignancy in the family. Family history. Is there any history of long-term disease that running in your family? Is there any history of any disease that runs in your family, similar condition, or any family history of any disease that runs in your family? And the third question, any condition of note like cancer or sudden death. Whenever the patient tell, yes, my mother died with cancer, thyroid, what is the diagnosis?
Medullary thyroid cancer.
What's that?
MEN2.
Yes, MEN2. Who said MEN2? Dr. Iqbal? Dr. Who said MEN2?
MEN2, yeah.
Yes, MEN2. Whenever you have family history, and this is how you get the diagnosis by taking proper history. Family history. Any similar conditions that runs in your family, any disease that runs in your family, any condition of note. Here, not a disease. Sudden death is not a disease. Any condition that runs in your family like cancer or sudden death. Cancer or sudden death. Okay. My mother died with cancer breast, and the patient is presented with constipation. What is the diagnosis?
She can see a breast with metastasis.
Yes, cancer breast with
Hypercalcemia.
metastasis. It's a hypercalcemia. So that's how you think in the exam. They will not give you irritable bowel syndrome. They will never give you tension headache. They give you cancer. If you are not able to consider cancer, there is ethical and medical and legal responsibility will fall on you. You are not able to diagnose cancer. The patient came, and it's a very common case in communication. Delayed diagnosis, missed the diagnosis. The patient came to you, and he said there is blood comes with the stool, and you give him proctoglyvenol and daflon, and you treat him as hemorrhoids. And later on, this patient proved to have cancer colon. So cancer is considered the top of the differential diagnosis, still proved otherwise. This patient should go for colonoscopy. Even in your life, in your clinical practice, in your clinic, send the patient for colonoscopy. You will lose nothing. Send the patient for colonoscopy. Whenever there is a bleeding the rectum or anal bleeding, send the patient for colonoscopy to relieve yourself from the medico-legal responsibility. You refer the patient to gastroenterologist for colonoscopy. The patient with bleeding the rectum, the patient coughing blood, the patient vomiting blood, the patient is losing weight, there is fecal occult blood, There's anemia without any known cause. You got patient 55 years old or 60 years old, and you find there's anemia, and you don't know upper and lower GIT endoscopy. This is routine in your life. Make it as routine. The patient is losing weight and there's unexplained anemia. Send for colonoscopy and OGD. This is the rule in medicine, in medical practice. Just play it safe. Never to give treatment while you are unsure about the diagnosis. So in life, in the exam, cancer. The patient, so past medical history of cancer or past family history of cancer, this is one of the indicators that your case is cancer. So the question to be asked, what type of cancer? If there is loss of weight, if there is anemia, how to ask about anemia? There is pallor, change in the appearance. It's not a change of the color of the skin. Color of the skin is jaundice or pigmentation in case of Addison, or sometimes some medication, or sometimes related to hemochromatosis. This is change in the color of the skin. But anemia, change in the appearance, pallor. Awareness of the heartbeat, racing of the heartbeat. This is anemia. Whenever there's manifestations of anemia, think cancer. Unexplained loss of weight, cancer. Put it on the top of the list. Other causes may be hyperthyroidism, may be related to chronic infections, may be rheumatoid autoimmune disease, may be any cause. Addison disease, hypoadrenalism, any cause. But whenever there is loss of weight, unexplained loss of weight, think about serious causes. What are the serious causes? Cancer, HIV, tuberculosis, or lymphoma. If we consider cancer, lymphoma, one of the commonest causes of anemia, hepatosplenomegaly, and anemia and loss of weight. So think about loss of weight. Diabetes, one of the causes of loss of weight. Diabetes. Hyperthyroidism. This is the scenario of loss of weight. What you should ask about, travel history. Travel history for tuberculosis and for HIV. Killer, fatal mistake. If you don't ask about travel history in case of fever, skin rash, chronic diarrhea, or loss of weight. You should think about travel history, HIV, tuberculosis. You should think about cancer. How to ask about cancer, family history, anemia, and loss of weight. Other manifestations, 100. You will find a big list of manifestations of cancer. Sometimes hemoptysis, hematemesis, melena. Sometimes it's related to skin rash. Sometimes it's related to night sweats. You will find a lot of manifestations. Big list. But exam-wise, it's related to abnormal or unexplained loss of weight, unexplained anemia. How to ask about anemia? Anemia, change in the appearance. Any change in the appearance? Yes, I have some change in the appearance in the form of pallor. Awareness of the heartbeat and racing of the heartbeat. Awareness of the heartbeat and racing of the heartbeat. These are manifestations of anemia in the exam. What are manifestations of heart failure? This patient with acromegaly, the main cause of this patient death is either heart failure or malignancy. Heart failure. What are the manifestations of heart failure? How you will ask about heart failure?
Breathing difficulty at night when lying down, orthopnea.
Orthopnea. How you will ask about orthopnea?
You need
how
to
people-
wake up at the night
Yes,
to
number of pillows. Number of pillows. Any change in the number of pillows. I used to sleep on 3. So the number is insignificant. But any change in the number of pillows you sleep on.
Mm.
Nocturnal.
Paroxysmal nocturnal.
Paroxysmal, nocturnal, this. How you ask about this?
Did you awake at night searching for the
Yes,
air?
yes. Awakening of sleep or awakening from sleep, gasping for air. Any awakening from sleep, gasping for air. Paroxysmal, nocturnal, this. And edema, swelling.
Diablum edema.
Yes, edema, swelling of the lower limbs. Sometimes there is hepatomegaly. Sometimes there is ascites. Sometimes there is shortness of breath. Sometimes there is pulmonary edema. Sometimes cough. Sometimes even hemoptysis. Do you agree? Yes or no?
Yes.
Okay. So you should know for each symptom how you ask. For each possible diagnosis and the differential diagnosis, what are the questions? So you want to rule out or in anemia. You want to rule out or in malignancy. You want to rule out or in heart failure. So you should know what is the cluster of question or group of question or the package of questions that you will ask for a certain diagnosis, like hypercalcemia. You should know what is the package for hypercalcemia. Rheumatological diseases. What is the package of rheumatological diseases? You should ask starting from here. Alopecia, skin rash, and the skin rash on exposure, on sun exposure, oral ulcer, oral sores, or private area sore. How you ask about private area sore? I will ask a private question. If you allow me, is it okay? Yes. Any private area source, is it painful or not painful? Behçet disease, oral ulcer, dryness of the mouth, dryness of the eyes, flaring of the vision, scleritis, episcleritis, iridocyclitis, inflammation or internal inflammation of the eye, iridocyclitis, part of the autoimmune disease, blurred vision, redness and gritty eyes, dry eyes and the dry mouth. What is the diagnosis? Sjogren syndrome. Thank you very much. So this is a part of any autoimmune disease. You should ask about rheumatological disease. Skin rash, butterfly rash.
SLA.
SLA. Gutron, babules, and heliotrope rash.
Dermatomyositis.
Dermatomyositis. Puckered mouth and tapered nose.
Systemic sclerosis.
Systemic sclerosis. And they will find sclerodactyly, you will find esophageal dysmotility, heartburn and acidity and dysphagia, difficulty of swallowing. So manifestations of systemic sclerosis. Sclerodactyly, you will find there is telangiectasia, you will find there is calcinosis, there is Raynaud's phenomena, any pain and change in the color of the hands and feet on exposure to cold. Raynaud's phenomenon. You should ask about the joints, which is the main target for most of the autoimmune diseases. Should ask about the hands. Any pain or stiffness in the joint, any swelling, any lumps and bumps, any change in the color, any pain, you should ask everything about the hands and feet. Then you should ask about general systemic manifestations. For autoimmune disease, the most important complication and the association is related to what? In the chest.
Coughing, breathing difficulty.
What is the condition?
Lung
Pulmonary
fibrosis.
fibrosis.
Pulmonary
I-
fibrosis, interstitial lung disease. Ask about
Mhm.
shortness of breath, ask about cough, ask about any sputum, any flame, what is the color? Sometimes it's complicated by pulmonary hypertension and sometimes related to or complicated by heart failure. Sometimes it's complicated by malignancy. Sometimes it's complicated by bronchiectasis. So chest, you should ask about chest. Sometimes it's related to pericarditis. Sometimes pleurisy, sometimes pleural effusion. Sometimes the most important and the killer in all autoimmune disease is about kidney. Nephropathy, renal crisis, proteinuria. How you will ask about proteinuria?
Through the urine.
First year. So never to, so put the map of the human being in front of your eyes while you are remembering the effect of the disease on different organs. So think about the hair, think about the eyes, think about the nose. Some vasculitis may lead to damage of the nose, may lead to chronic sinusitis. What are the causes of chronic sinusitis in a patient with vasculitis?
Granulomatosis.
Granulomatosis with bronchitis.
Yes, granulomatosis with polyangiitis. Before it was called Wagner syndrome and Churg-Strauss syndrome. So these are vasculitis which will cause renal disease, and these are autoimmune disease and will lead to nasal manifestations and the chronic cough and asthma-like. So whenever you have patient with hematuria and shortness of breath and the dry cough, think about vasculitis, Churg-Strauss or Wagner syndrome. Vasculitis. Vasculitis, one of the most important and difficult scenarios in the exam, but it should be considered. Put it in your mind whenever you are giving the differential diagnosis. Vasculitis, one of the presentations or one of the forms of autoimmune disease. Okay, as we agreed, autoimmune diseases, packages. So rheumatological diseases start from the hair, the eyes, the nose, the mouth, the neck, raised JVP, heart failure related to pulmonary hypertension and related to fibrosis, interstitial lung disease or pulmonary fibrosis. So these are very important manifestations of any rheumatological disease. Kidney, GIT, the patient is taking a lot of non-steroidal anti-inflammatory and analgesics, and even corticosteroids will cause gastritis, will cause microscopic colitis, sometimes even diarrhea and bleeding. These are very important manifestations of all autoimmune disease. What are the associations? Type 1 diabetes, Addison disease, Hashimoto's, think about the thyroid, Hashimoto's or Graves, pernicious anemia, inflammatory bowel disease, bowel disease.
Celiac disease, vitiligo.
Yes, 3, skin, vitiligo, psoriasis, bullous pemphigoid, pemphigus vulgaris. 2, important neurological. What are the autoimmune neurological? Multiple sclerosis and myasthenia gravis. Multiple sclerosis and myasthenia gravis. A lot of other diseases, Charcot-Marie-Tooth, Kennedy's disease. You will find a lot of causes, but I don't want to just confuse you, because actually you will find all this information on the videos, the recorded sessions. You will find all the differential diagnosis neurologically, take it part by part. But the most important autoimmune diseases, we should think about the commonest disease. Celiac disease, 3 in GIT. Crohn's disease,
Ulcerative colitis, celiac.
ulcerative colitis, and celiac disease. These are the most common GIT disease. Pernicious anemia, intrinsic factor deficiency, and antibodies against parietal cells. Pernicious anemia, hypothyroidism, Hashimoto's, Graves' disease, Addison, all autoimmune disease, type 1 diabetes, Addison disease, Graves. So these are one package. Whenever you have one, ask about the others, even in brief, but put it in mind. Whenever you have debilitating disease, think about lymphoma, think about cancer, malignancy, and think about tuberculosis and HIV. This is one family, one package. Whenever you get one, you should think about others. So whenever you have a patient with HIV, think about cancer. What is the most common type of cancer in HIV?
Burkitt disease.
Kaposi sarcoma.
Kaposi
Sarcoma. Kaposi sarcoma, and it's a spot diagnosis. Kaposi sarcoma. Okay, so these are combinations in the exam. You will find there is some relation between some disease. This is what is called associations. Acromegaly. Dermatomyositis. Yes, please.
Autoimmune disease, HIV, and cancer.
No. This is one other package. These are debilitating diseases. Whenever you have debilitating disease, think about autoimmune disease, think about HIV, think about cancer, think about lymphoma. These are debilitating disease. Whenever, because actually autoimmune disease, one of the most difficult to diagnose, because we are not autoimmune oriented. We are not autoimmune oriented. So you will get a patient with fever of unknown origin. You will get a patient with joint pain. You will get a patient with difficulty in swallowing. You will get a patient with joint pain. You will get a patient with loss of weight, with fever, with any manifestation. These are non-specific manifestations. And you don't think about autoimmune disease. In the exam, whenever you go to the exam, for any station, ask the patient to remove the mask. Because you have a spot diagnosis in the face. Look at this patient, dermatomyositis, heliotrope rash, and Gottron babules. This is spot diagnosis. Heliotrope rash. Heliotrope rash, sometimes it's helio means what? What is the meaning of helio?
Sun.
Sun. It's the sun. Helio is the Latin word for the sun. So this is sun-related skin rash. Skin rash on sun exposure. What are other area? It's the V-shaped area in the neck. Chest. المنطقة اللي هي بتاعت الياء. The exposed area to the sun. Gottron babules on the hands. These are sun exposure rash. Skin rash on sun exposure. Systemic lupus erythematosus. This is very characteristic rash, which is butterfly rash, and you will find a lot of causes of butterfly rash. Here, it's lupus erythematosus. This is photosensitive, sun on sun exposure. And this very important question to be asked to all patients, any skin rash or any skin rash on sun exposure. Very important, because it's non-specific and you'll find no place to ask except while you are analyzing the presenting complaint. These are the important questions for any case in order to diagnose. Any fever, You ask about associations of the symptom. The patient is presented with diarrhea. The patient is presented with joint pain, any fever, any skin rash or skin rash on sun exposure, any lumps and bumps. These are very important questions. Polyuria or polydipsia, nausea or vomiting, feeling sick or throwing up. Polyuria and polydipsia, feeling thirsty, drinking too much water, and passing too much waterworks. How to ask about polyuria and polydipsia. These are very important questions to be asked for any case. Skin rash and skin rash on sun exposure. Lumps and bumps. Any change in your body weight, very important question, because this question will give you a hint about the diagnosis. It's not losing weight or gaining weight. Any change in your body weight. Yes, I'm losing weight. How many kilograms? Over how long? Is it intentional or unintentional? Any change in your food habits? This is the package or the cluster for body weight. Gaining or losing? Cancer. Let's say Eileen, cancer. Cancer, losing weight. The patient is losing 10 kilograms over the last 1 month without any change in the food habits, and it's unintentional. He is not using Ozempic or using Mounjaro or anything for losing weight, and he lost or she lost 10 kilograms over the last 1 month. Red flag, cancer or hyperthyroidism. And the easiest diagnosis in the exam is hyperthyroidism. There is loss of weight, shaking of the hands, lack of sleep, insomnia, racing of the heartbeat, tachycardia, headache, irritability, nervousness, depression, and in premenopausal ladies, there will be amenorrhea. Menorrhagia equal hypothyroidism. In menorrhagia, this is how you know your patient is euthyroid or hyperthyroid or hypothyroid in premenopausal lady. Hypomenorrhagia, polymenorrhea. Hyperamenorrhea. And those patients are suffering all the time. They are not able to sit, they are not able to talk, they are not able to sleep, and they are pulsating all the time, palpitations and high blood pressure and tremors and proximal myopathy. So what are the causes of proximal myopathy? That you know, I need an answer. Causes of proximal myopathy.
Doctor, maybe hereditary or acquired?
I mean acquired. Hereditary, it's okay, it's known, but I mean acquired.
Cushing syndrome.
Yes. So let us talk about two important causes: autoimmune disease and endocrinological causes. All endocrinological causes or diseases can cause proximal myopathy. Whatever. Diabetes will cause proximal myopathy. Do you agree?
Yes.
Cushing syndrome, acromegaly, hypothyroidism, hyperthyroidism, Addison disease. So all endocrinological or endocrinopathies are causes of proximal myopathy. Autoimmune, all whatever you remember. Polymyositis, dermatomyositis, rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, Sjogren syndrome, whatever you remember from autoimmune disease can cause proximal myopathy. So proximal myopathy in neurology, it should be considered whenever there is weakness. So proximal myopathy puts the differential diagnosis, acquired or congenital, and acquired, you should think about all causes of myopathy. dermatomyositis, polymyositis, systemic sclerosis, even rheumatoid arthritis, Sjogren syndrome, mixed connective tissue disease, systemic lupus erythematosus, whatever you just remember. Even fibromyalgia causes weakness. It's not related to weakness, it's related to pain. It's not related to myositis, it's related to myalgia, pain, fibromyalgia. There is a disease which is associated with cancer and associated with autoimmune disease, which is temporal arthritis. It's called polymyalgia rheumatica. It's myalgia. It's not myositis. It's pain and weakness of the proximal muscle. And weakness not related to myositis, it's related to myopathy. Polymyalgia rheumatica. It's highly associated with cancer and highly associated with temporal arthritis or giant cell arthritis, which is a type of autoimmune vasculitis. So it's very important to ask about the muscles. Any problem with combing the hair, look, I want you, anybody who is taking note or will take note later on, look for how many symptoms and the questions you can ask the patient. This is history taking, long cases, how you can ask questions about everything. So asking about myositis, combing the hair, going upstairs, going downstairs, getting something from a high shelf, touching the hair, touching the head, all these are related to proximal myopathy. Proximal myopathy. This is a case of weakness, proximal weakness, and you will find there is ad-dofda, frog. In proximal myopathy, the patient will have waddling gait, and frog-like position, because here abductors will be strong while adductors will be weak. So there is separation of the hip. The thighs are separated. This is white base, and there will be waddling gait. Waddling gait because of the weakness of the muscles of the hip joint. Waddling gait. So it's very important to ask a patient and to know how to ask a patient about the manifestations related to proximal myopathy. So it's very important to be aware of the questions about every symptom in the exam in order to rule out or rule in any disease. Proximal myopathy. Okay. This is systemic lupus erythematosus. This is systemic sclerosis. And I love this case because it's very common in the exam and very common in the clinics, but we don't notice. We don't notice. Look at these faces, you will find tapered nose. The nose is very characteristic. Tapered, small tapered nose, and puckered mouth. Puckered means that there's some like the birth. So you will find very narrow mouth, very narrow. Even if you ask a patient to put 3 fingers in the mouth, they will not be able. It's rounded and there is a lot of wrinkles around the mouth. This it's called puckered mouth. مكرمش. Puckered mouth. So this is very characteristic faces. You will find also in these faces, you will find there is telangiectasia. Telangiectasia, there is some dilatation of the capillaries. Ectasia means dilatation. Ectasia. Like bronchiectasis. Bronchiectasis means ectasia of the bronchi and the bronchioles, dilatation of the terminal bronchioles, accumulation of secretions and chronic infection, and too much pus and secretions, and sometimes it turns into like lung abscess. So this is a case of spot diagnosis, systemic sclerosis. So Packard mouse, tapered nose in lay person, which is not used language. This patient has bird nose and fish mouth. Never to use this in the exam. But I'm giving you the expression in order to know how it looks like. It's a spot diagnosis and telangiectasia. In the hands, you will find small infarcts. This because of Raynaud's phenomenon, lack of blood supply. You will find a change in the color of the hands. You will find shining, stretched skin, scleroductile. Whenever ductile means fingers. Scleroductile. Try to bench the skin, it's not benching. Very common case in the exam. And you'll find calcinosis. Calcinosis is more evident and more prominent in the X-ray. Accumulation of calcium deposits under the skin. But over these deposits with this scleroductile and Raynaud's phenomenon and lack of skin supply of blood supply, this will lead to skin infarcts. You'll find some skin infarcts. Calcinosis, telangiectasia, crest, calcinosis, Raynaud's phenomenon, R, E, esophageal dysmotility, S, scleroductile, T, telangiectasia. This is spot diagnosis. I love this case, and be sure this case will come in your coming exam. This is called chipmunk appearance. Anybody knows what is the chipmunk? Can you hear me?
Singap.
A Singap. Yes, yes. That's right. That's right. Chipmunk. Can you use this in the exam? No. You should say this
No.
is thalassaemic facies. The thalassaemic facies. What is the thalassaemic facies? There is bossing of the frontal bone because actually in this patient, the blood is all the time is hemolyzed, distracted by the spleen and all abnormal hemoglobin. So all the blood cells, red blood cells, are distracted. So we need a lot of production. So the production will be overproduction from the flat bone will lead to change in the appearance of bones. There will be bossing of the frontal bone. There will be prominence of the zygomata. The zygomata, the zygomic bone or zygomatic bone, it's related to this bone, cheekbone. Prominence of the cheekbone and the proximal prominence of the maxilla and exposure of the frontal teeth. Due to here, it's the opposite to acromegaly. Acromegaly, it's related to growth hormone. So the prognathism protrusion of the lower jaw. Here, the maxilla will be protruding. That's what gives the chipmunk appearance. Chipmunk appearance. And there is a very important characteristic complexion. What is the complexion? What is the color of
Muddy
the skin?
complexion.
Muddy complexion. Never to use this in the exam. What you will tell? Thalassaemic complexion. What is the thalassaemic complexion? The three components of thalassaemic complexion.
Pallor, jaundice, and bronzed skin.
Due to
Hemochromatosis.
secondary hemochromatosis.
Secondary hemochromatosis.
Yes. So here in this patient, very important, and please give me all your attention and all your ears, because this patient will see in the exam. you'll see this patient in the exam. So the complexion, this patient is using all the time, using what? Blood transfusion. He is treated with blood transfusion and iron chelating agents. So blood transfusion, too much iron. If you don't give iron chelating agent, even if you give, you will find there's increased iron in the blood. So this will lead to secondary hemochromatosis due to destruction of red blood cells and too much iron in the blood. So this patient, you will find 2 scars in the abdomen. What are the scars in the abdomen?
Cystectomy, scar mark, splenectomy.
Yes, splenectomy and cholecystectomy. And usually these are done by either endoscopic or sometimes open scars. Okay. Is there any possibility this patient, whenever you examine, you expect what in the abdomen?
Either
Splenomegaly.
splenomegaly or hepatomegaly with splenic scar.
Yes. You'll find hepatomegaly with splenectomy or splenomegaly. So if there is a scar, expect there is no spleen. If there is a scar, expect no spleen. You'll find no spleen. If there is left hypochondrial scar, or sometimes it's done now by endoscopy or by robotics, you will find very small scars in the abdomen or midline scar, abdominal midline scar. There is a splenectomy. Whenever you are examining the patient, you'll find no spleen. Even by percussion on the trapeze area, you will find no spleen. Okay. Do you expect to find stigmata of chronic liver disease in this patient?
No, doctor.
So the normal or the expected, no stigmata of chronic liver disease with hepatomegaly. So there will be hepatomegaly due to the chronic hemolytic anemia. Chronic hemolytic anemia, here in this patient, the liver, the erythropoietic extra medullary erythropoiesis, the body uses all the sources of production of red blood cells. One of these sources is the reticuloendothelial system found in the liver. So there is hepatomegaly. Usually in this patient, you'll find hepatomegaly, either hepatosplenomegaly or hepatomegaly with splenectomy with no stigmata of chronic liver disease. If you find the stigmata of chronic liver disease, what are the causes of stigmata of chronic liver disease in this patient?
Cirrhotic liver
Editing hemochromatosis.
from secondary
Secondary
hemochromatosis.
hemochromatosis.
Secondary
Maybe.
hemochromatosis or
Viral hepatitis.
viral. Thank you very much. Thank you very much, Dr. Asaf. Viral hepatitis because of repeated blood transfusion. So this patient may be prone to hepatitis B or hepatitis C, blood-borne viral hepatitis, or related to secondary hemochromatosis. In secondary hemochromatosis, expect to find diabetes, expect to find hypogonadism, expect to find hypopituitarism, expect to find atrophied testicles. You will find lack of secondary sexual characters. You will find all manifestations of hypogonadism. Okay. What are the causes of chronic hemolytic anemia? I need all to participate. Whatever you know, Unmute and tell the causes of chronic hemolytic anemia.
Thalassemia, hereditary spherocytosis,
sickle cell
and
anemia.
G6PD.
sickle cell anemia, G6PD, other warm and cold antibody, like
Okay.
autoimmune.
Hemolytic anemia, and sometimes you will find there's spherocytosis, elliptocytosis. So any abnormal red cell wall, any abnormal cell wall, or any abnormal hemoglobin, this will lead to destruction of red blood cells. Elliptocytosis or spherocytosis, abnormal wall. In case of sickle cell anemia, there will be abnormal shape of the cells. Thalassemia, abnormal hemoglobin. Is there any possibility to find splenomegaly in sickle cell anemia?
Yes, early disease, there can be splenomegaly, then autosplenectomy.
Autosplenectomy will mean what? It means that this
Spleen.
patient has no surgery, but very, very small shrunken spleen. Because of the sickled cells will close the small blood vessels. This will close the small capillaries and the small blood vessels. The sickled cell, the normal red blood cells, these are biconcave and disc-like. This enables the red blood cells to change the shape of the wall while passing through small capillaries. In case of sickle cell anemia or spherocytosis, the abnormal shape will cause red blood cells to hemolyze, will be destructed. And the spleen will take these cells and will destruct these cells. That's why there is a splenic. But in case of sickle cell anemia, in sickle cell anemia, there will be infarction of the spleen because of lack of blood supply. The most common presentation of patients with sickle cell anemia is pain. The pain is due to ischemia and infarction of internal organs. Sometimes they give tramadol and morphine for those patients to relieve the pain of infarction of internal organs. So the spleen will be shrunken. So in case of sickle cell anemia, and this they love, the examiner loves this question in the exam. What are the causes of splenomegaly?
I think
Sequestration
doctor,
crisis.
sequestration crisis.
What's that?
Sequestration crisis.
Yes, yes, there will be destruction and there will be pain and there will be closure of the small blood vessels. These are ischemic pains. What are the causes of splenomegaly?
If associated with thalassemia, sickle cell, thalassemia together.
So let us say related to chronic hemolytic anemia. Let us take the causes of splenomegaly as chronic hemolytic anemia. Do you agree?
Yes.
Okay, so you will put all the causes even. In case of spherocytosis, in case of elliptocytosis, in case of thalassemia, in case of any hemolytic anemia except for sickle cell anemia. So never to mention sickle cell anemia as a cause of splenomegaly. Okay. What about the bone marrow depression? What are the causes of bone marrow disease?
Parvovirus infection.
Okay.
Myelofibrosis.
What else? Myelofibrosis.
Aplastic anemia.
Yes, aplastic anemia, myeloproliferative diseases, leukemia, lymphoma.
Immunosuppressant.
Immunosuppressive disease or immunosuppressive medication. Even some autoimmune disease will lead to bone marrow depression. Some medication,
Methotrexate.
methotrexate. What about carbimazole? Carbimazole. So we call as a group myeloproliferative, although there is some like bone marrow depression in case of myelofibrosis, one of the causes of huge spleen. Myelofibrosis comes in old age, sometimes it's idiopathic, even without any medication or any primary cause. There is in old age, there is what's called the myelofibrosis. The spleen will be huge. What about some infections and some infestations, like malaria, bilharziasis, leishmaniasis, one of the causes, and some tumors like lymphoma and leukemia. You'll find huge, especially chronic myeloid leukemia, you'll find huge spleen. Huge spleen. And in malaria, leishmaniasis, Kala-Azar, you will find huge spleen. One of the questions that may be asked by the examiner, what are the causes of huge spleen? What if the spleen is very small? Whenever you are examining and palpating for spleen, you don't feel the spleen below the left costal margin. Just for percussion. Percuss, what is called Tourbe's area. Tourbe's area, this is the area between the anterior axillary line and the costal margin and the costal margin and the fifth rib, left side, you percuss in the Tourbe's area. Percussion in the Tourbe area, this Tourbe area usually is resonant because here you percuss over the stomach air bubble, the gas in the stomach. So if you find this area is dull, this means that there is splenomegaly before emerging below the left costal margin. This is called Castell sign. Castell sign. This you should know in clinical examination of the abdomen to detect very small spleen. Very small spleen in the Tourbe's area before emerging below the costal margin. So thalassemia is very important case in the exam, and I expect to find this case by percentage of 90%. 90%. You'll find the patient in Jeddah. This patient is a young man who has a splenectomy. You'll find the scar of splenectomy, and you'll find there's endoscopic cholecystectomy, and this patient has the same and the very characteristic and features, all features of thalassemia major. Parkinson or Parkinsonian phases. These Parkinsonian phases, usually the patient is depressed, and you will find there's this patient is expressionless, no expression on the face. You will find there is sometimes this very rare blinking, and you'll find the main characteristics of Parkinsonism in this patient, which are bradykinesia, tremors, which is resting tremors, pill rolling tremors, and rigidity. Very characteristic. You will find the shuffling gait, small step gait, or Abuti march, small step gaits. Very, very characteristic. and the shuffling gait. Shuffling gait, the patient is, all the joints are flexed, starting from the back to the neck, to the elbows, to the hips, all joints are flexed. And small steps. Spot diagnosis. Expressionless face. Infrequent blinking. Depression. Mask-like. Absent or reduced blinking. Staring. Vacant look, usually is related to depression. And dribbling of saliva. Sometimes you find weakness of the upward gaze. This what is called supranuclear Parkinson plus. Parkinson plus, you will find sometimes if you put your finger up and ask a patient to look up, he will not be able to look up. Up means supranuclear palsy. Multiple system syndrome, multiple system syndrome, you will find there is Parkinson plus. Other systems are affected, mainly the cerebellum. So there will be plus Parkinsonism, rigidity, tremors, and bradykinesia. You will find there is some other manifestations. You will find there is other manifestations. So these manifestations are related to cerebellar syndrome. And also you will find there is affection of the autonomic nervous system. There will be postural hypotension, and sometimes the area of constipation, and you'll find the change in the sweating, and you'll find some manifestations of failure of the autoimmune system. This is multiple system atrophy or multiple system syndrome. Parkinson's plus. So Parkinsonism is very important case in the exam. It's a spot diagnosis. You should examine the patient for bradykinesia, should examine for tremors. Tremors are spot diagnosis. You will find that there is the patient usually is trying to support his hand to avoid these tremors, which is bill rolling tremors, resting tremors, rigidity, and there is bradykinesia and tremors. This is myotonia dystrophica. Spot diagnosis. Myotonia dystrophica. This is myopathic fascias. So myopathic fascias is very characteristic. All these diseases we talked about are spot diagnosis. So what you need to do is to know what are the characteristic symptoms and signs. So here you should talk about, you should know how to describe these fascias. There is baldness, frontal baldness, there is bilateral ptosis, there is long, lean, triangular hatchet fascias. The patient looks depressed, sad, expressionless face, and wasting of the temporalis and the masseter muscles. So you should know what is the frontal balding, what is the temporalis and the masseter wasting, how the face looks like, and the most important is about weakness of the muscles will lead to bilateral ptosis, like the fascias of myasthenia gravis. Here it's this myotonia dystrophica. You will find wasting of the muscles of the hands, wasting of the muscles of the hands, and you will find there is dystrophica, means that there is difficulty in growth, and myotonia means increased in the tone. Whenever you tap, you find the spasm. Whenever you shake hands, the patient will not be able to withdraw his hand. So this is what is the explanation of the name. Myotonia dystrophica. Myo means muscle. Tonia, increased in the tone. Dystrophica, atrophy of the muscle, wasting. Temporalis muscle, masseter muscle, the hand muscle, the foot muscles, you will find wasting of the muscle. And look here for myasthenia gravis. This is myasthenic facies. Myasthenic facies, the most characteristic features in myasthenia is fatigability. So those patients will just have this weakness and ptosis and all manifestations of muscle weakness after exertion. So if you ask the patient to look up, he will drop the upper eyelids suddenly. After a few seconds, the patient will not be able to keep the eyes up. And usually there is weakness of the even extraocular muscles. The patient is not able to do the H-shaped test. There will be double vision. And here, this patient, usually, whenever you have this patient in the exam, the examiner will tell you, please examine this patient with double vision. Double vision, whenever looks to the sides, he will have double vision due to weakness of the extraocular muscle. So snarling faces شكله زي ما يكون عايز ينام يعني أو نايمان أو نص نايم sleepy. Mostly there is no wasting of the muscle because the muscles are weak on exertion. These are fatigability, so you will never find wasting of the muscle, but you will find weakness. And this is one of the types of differential diagnosis of weakness due to neuromuscular junction. The other causes, Lambert-Eaton syndrome, calcium channels or calcium bumps, and in case of botulism. These are the causes of neuromuscular junction syndrome. Myasthenic facies, myasthenia gravis, sleepy. You find that the patient as if is not able to open the eyes. And usually the fatigue and weakness is mainly by the end of the day. Or after exertion, there will be weakness and lack of energy. Down syndrome, no need to talk about because actually we all have seen cases, a lot of cases around us about Down syndrome. Turner syndrome, you will find short and webbed neck, low hairline, and redundant skin fold on the back of the neck. Turner syndrome. What is the most important cardiological or heart lesion in this patient?
Coarctation of the aorta.
Coarctation of the aorta. What else? What is
aortic valve?
bicuspid aortic valve? Sometimes. What about Down syndrome? What is the main lesion in Down syndrome?
VCD.
Atrioventricular Cushing defect.
Okay, so atrial septal defect or ventricular septal defect. What the cardiac lesion in Marfan syndrome?
Aortic regurg.
Regurgitation, mitral valve prolapse.
Mitral valve prolapse. Sometimes even dilatation of the aortic valve.
Aortic root.
Aortic root. So this is supravalvular aortic regurgitation. Failure of the valve to closed because of the dilatation of the aortic root. Sometimes even in those patients, you will find there's defective aorta or even problem with the wall of the big blood vessels, sometimes aortic aneurysm or dissection of the aorta. So you will find a lot of problems related to fibrillin defect. Fibrillin is the main component of connective tissue. Connective tissue is the main component of valves and connective tissue in the ligaments, in the joints, in the skin. So that's why this explains the manifestations, cardiological manifestations related to blood vessels and related to the valves. Mitral valve prolapse or aortic root dilatation. This is Marfanoid fasciitis, Marfan syndrome. Marfanoid fasciitis. Little bit, it looks like acromegaly, but actually you find no bossing of the frontal bone, no prominence of the supraorbital ridge, no big mouth, big nose, big lips, big ears, but it's elongated face. So it's lean, elongated, and narrow with a small jaw. No macroglossia, no prognathism. And high arched palate. Take care about examining the mouth because high arched palate is a spot diagnosis. In some cases, you will find the spot diagnosis by high arched palate. High arched palate is very important characteristic for all this family. This family is what we call collagen inherited or congenital collagen disease. Acquired collagen disease, this all rheumatological autoimmune disease, connective tissue disease. Here, this family is called the congenital or inherited or hereditary or familial collagen disease. Anybody can tell me what are the group of familial or congenital collagen disease?
Ehlers-Danlos syndrome, osteogenesis.
Ehlers-Danlos syndrome. What else?
Osteogenesis imperfecta.
Osteogenesis imperfecta.
Pseudoxanthoma elasticum.
Yes, pseudoxanthoma elasticum and Marfan syndrome. All are almost the same, except in Marfan syndrome, there will be disproportion between the height and the arm span. The tall patient, sometimes Ehlers-Danlos syndrome is almost the same, but without tall patient within or disproportionate the arm span with the height span. So these patients all have some problem with the collagen or fibrillin or the fibers of the connective tissues. All manifestations, easy porosis, non-healing wounds. You will find there is hyperflexibility of the joints, hyperextensibility or flexibility of the skin. You will find there is sometimes pneumothorax, spontaneous pneumothorax, congenital or heart disease. You will find almost the same manifestations in all these diseases. Osteogenesis imperfecta, spot diagnosis. Blue is clear. Spot diagnosis. You don't need any test or anything to do in order to diagnose osteogenesis imperfecta. Ehlers-Danlos syndrome, you will find a lot of scars. You will find there's scars of pneumothorax, drainage of pneumothorax. You will find there is porosis. Sometimes you find there is hyperelastic skin. You will find there is hypermovable joints and all the manifestations, but no change in the height span related to the extended arm span. Mitral fasciitis, here one of the causes of malar rash. Mitral fasciitis, here should know the difference between skin lesions, as in systemic lupus erythematosus or sarcoidosis, lupus bernium. Here are skin lesions. These are granulomatous diseases. You'll find the skin lesions. In case of mitral fasciitis, it's related to the blood vessels. So the malar rash here, it's only flushed cheeks with dilated capillaries. It's not skin lesion. So that's why whenever you find malar rash, look, if it is related to the capillaries, think about telangiectasia, think about mitral fasciitis. It's related to dilatation of subcutaneous capillaries due to nitrous oxide, vasodilators, accumulation of some vasodilator substances under the skin. In case of telangiectasia, it's dilatation of the small capillaries under the skin. In case of the spider nevi are related to estrogen. Spider nevi you may find normally in pregnant women. And in case of liver cell failure, because of accumulation of estrogen. The liver is not able to destruct or metabolize estrogen coming from the suprarenal gland. So this is the cause of palmar erythema and the cause of spider nevi, enlarged capillaries. So this mitral fasciitis, it's related to mitral stenosis. Nephrotic fasciitis, nephrotic syndrome, sarcoidosis. Sarcoidosis, you will find very characteristic rash, which is lupus bernium. And here you will find lupus bernium may be found on the tip of the nose, may be found on the cheeks. It's very similar. You will never be able to differentiate the skin rash between sarcoidosis and systemic lupus erythematosus, the malar rash. You will never be able to differentiate by looking or by examining by the eye. How you can differentiate? The nasolabial fold. If the nasolabial fold is involved and the tip of the nose, it's related to lupus bernium. If it is not involved, mostly it's related to systemic lupus erythematosus. And in sarcoidosis, look for other manifestations. Erythema nodosa in the lower limbs. You will find sometimes lymph nodes. And you'll find chest manifestations, which may be found in systemic lupus erythematosus or sarcoidosis, pulmonary fibrosis, or interstitial lung disease. But the most important differentiation between sarcoidosis, if you are taking as a short case and will never happen in the exam, they give you systemic lupus erythematosus or systemic sclerosis or dermatomyositis or rheumatoid arthritis. Sarcoidosis, you should look, if you are taking this case, look for the lower limbs. If you find there is lower limb erythema nodosum, it's a case of sarcoidosis. Look for the nasolabial fold. Which part the nasolabial fold is the area between the nose and the mouth, the upper lip. This is called the nasolabial fold. If it is involved, it's related to sarcoidosis. Lupus bernium. Bell's palsy, 7-nerve palsy. Leonine face, leprosy, achondroplasia. This may come in the exam as short stage. Very characteristic, and you will never miss this case in the exam. It's achondroplasia or hypochondroplasia. Sturge-Weber syndrome, this is port wine stain, and the importance and significance of this, that this may be associated with cancer. Sturge-Weber syndrome, spot diagnosis. Sturge-Weber syndrome, it's a tumor of the blood vessels. They call it port wine stain. This is Paget disease. Is there any similarity between this and acromegaly? There is pulsing of the frontal bone. Is there any similarity?
compressive of the nerve.
Okay, so in acromegaly, you may also find sometimes compressing of the auditory nerve, but the only looking at the patient, you will find different features, because in acromegaly there is enlargement of the soft tissue, so you'll find enlargement of the lips, enlargement of the nose, enlargement of the ear. All the soft tissues are enlarged. Here you may find bossing of the frontal bone, prominence of the supraorbital ridge. You may find even prognathesm, but no macroglossy. And you'll find bowing of the lower limbs. So this is different. And even if you look at the hands, you will find no acromegaly. Acro means what? Anybody? Acro means what?
Large
Hands and feet.
Yes, extremity.
large hands.
Hands and feet, fingers and toes. Acro, this acro means the fingers and toes. So acromegaly means that there is enlargement of the toes and the fingers. That's why you call it spade-like. Spade means what? Maghraf. For food, spade, spade-like. So Paget disease. Hepatic phases, you will find atrophy of the temporalis muscle. The muscles of the face are atrophied. And you find all the information in the abdominal recordings. All the manifestations and all stigmata of chronic liver disease, you'll find in the 2 or 3 lectures about abdomen. Stigmata of chronic liver disease. So you'll find here temporalis wasting of the temporalis muscle. Sometimes enlargement of the parotid glands. Sometimes joints. Sometimes you will find there is slide of nevi on the face and the neck. So you will find a lot of manifestations in this patient with hepatic phases. You will find gynecomastia, you will find asterexis, you will find there is Dupuytren's contractures, palmar erythema, you will find sometimes clubbing. So a lot of manifestations, what we call stigmata of chronic liver disease. So muddy or pigmented discoloration, pinched face and sunken eyes, prominent malar bones, atrophy of the temporalis muscles, and sometimes parotid enlargement. Superior vena cava obstruction. ده ما اعرفش مين بصراحة. This is bilateral parotid swelling, most commonly in alcoholics. Dupuytren's contractures and enlargement of parotid glands you may find in patients with diabetes in case of hepatic disease, or I mean chronic liver disease, or sometimes in alcoholics. Other causes may be Sjogren syndrome, sarcoidosis, mumps, amyloidosis, hypothyroidism, alcoholism, diabetes, and in case of chronic liver disease. This is the bilateral chronic parotid swelling. Sometimes tumors. If unilateral, you should think about tumors. Sometimes obstruction of the duct with the stool. Android facies, amiodarone facies. Look for the color of the skin. This color of the skin is very characteristic. This is like grayish. So discoloration, the differential diagnosis of discoloration of the skin, think about medication like amiodarone, think about Addison disease. What is the cause of pigmentation in Addison disease? This is a question.
MSH
CTH.
secretion.
Yes, adrenocorticotrophic hormone, usually whenever it's high, it's associated with melanocytic stimulating hormone. So there will be whenever there is, that's why in case of adrenalectomy, there is what's called the Nelson syndrome. Nelson syndrome. After some time, the pituitary gland will be enlarged and too much secretion of adrenocorticotrophic hormone and melanocyte stimulating hormone. So the patient will be pigmented and there will be sometimes manifestations of macroadenoma of the pituitary gland. Pigmentation related to increased adrenocorticotrophic hormone, which is associated with melanocytic stimulating hormone or melanocyte stimulating hormone. MSH. What else? What is the commonest and the most important cause of skin pigmentation in your life?
Hemochromatosis.
What's that? I couldn't hear.
Sir, hemochromatosis or no.
What is the most important cause of skin pigmentation?
Hemochromatosis.
Hemochromatosis. In the exam, whenever you get a patient with skin pigmentation, it's bronze diabetes, the bronze color. Our colleague, whenever I was asking about the complexion of, he said bronze color of hemochromatosis. It's a bronze discoloration. Grayish discoloration, it's related to renal failure. You should know. Yes, Dr. Fazlur Rahman, the most important cause is Addison disease or adrenal failure. Any cause of adrenal failure. Primary adrenal failure will lead to too much adrenocorticotrophic hormone, or sometimes it's related to not Addison disease. Sometimes even there is any pituitary tumor which is secreting adrenocorticotrophic hormone will be associated with MSH, melanocyte stimulating hormone. Medication as amiodarone. For the exam sake, think about renal failure, think about hemochromatosis, think about primary adrenal failure for any cause. What is this?
Immediate nodule.
Rheumatoid nodule.
What is the differential diagnosis?
Immediate nodule. Tophi.
Yes,
Okay.
gouty,
Gout.
tophi, or tophaceous gout. Gouty, tophaceous gout, or gouty, tophi. So tophaceous gout or rheumatoid nodules. Even in osteoarthritis, sometimes you find nodules, but on the hands. So this is very important. That's why whenever you are examining the patient, show me your elbows. What are the important points that you will see in elbow?
Vitiligo.
Vitiligo. What else?
Psoriasis rash.
Psoriasis. Yes,
Psoriasis.
doctor.
Psoriasis.
Yes, yes, yes. Psoriasis, look for psoriasis and vitiligo in the elbows, in the hairlines, in the mouth. Look for rheumatoid nodules, tophaceous gout. Where is the best place to see tophaceous gout?
The ear.
Yes, in the ear
In
bend.
ear.
Yes, ear lobules and ear bend. You will find tophaceous gout. It's very painful because this is the position of uric acid salts under the skin. So tophaceous gouts are very painful. While these rheumatoid nodules are usually painless. Common size of rheumatoid nodules. The metacarpophalangeal joints over the dorsum of the hand at the wrist and on the elbow. Rheumatoid nodules. This is the rheumatoid hand. The most important point in rheumatoid hand, you should differentiate between real deformity from reducible or reversible deformity. So in rheumatoid nodules, these are related to inflammation of the joints. You will find there are many ways of deformity. You will find sometimes what's called the swan neck deformity. You will find boutonniere deformity, the Z-shaped thumb, and you'll find luxation of the metacarpophalangeal joints and ulnar deviation. And this is very important because this is the commonest case in the exam. In rheumatology, expect this case in the exam. So you should know how to describe the deformity to the exam. Boutonniere, you will find terminal extension and the proximal flexion. Swan neck, proximal extension and distal flexion. The opposite. Boutonniere, the dressmaker, whenever he holds the needle to fix the buttons. Boutonniere deformity. And in the if you listen to the rheumatology lecture, the recording, you will know everything about rheumatology. Will be the easier or the easiest station ever in rheumatology in the exam. The deformities and how to differentiate between the nodules, osteoarthritis, Heberden, and Bouchard nodules. What is this?
Psoriasis.
Spot diagnosis.
Psoriasis.
So whenever you find psoriasis, this is spot diagnosis. You know that this patient has psoriatic arthritis. It's similar to rheumatoid arthritis. Very similar. But sometimes it comes more aggressive and it's not symmetric. And sometimes there is what's called dactylitis. You'll find inflammation of the whole finger, not only the joints. One of the most aggressive types of arthritis. It's autoimmune disease, and arthritis will cause damage to the joints. You can differentiate between rheumatoid arthritis and psoriatic arthropathy by the distribution of joint and the shape of the fingers and the lesions. Whenever you see these lesions, it's not rheumatoid. Cut it short. So that's why show me your hands. Show me your elbow. Whenever you go for rheumatoid or locomotor station, show me your elbows. Look at the hairline. Look behind the ears. Look at the ear bend. Look at the face. Look at the hands. So spot diagnosis. Whenever you find this lesion, this is the case of arthropathy. In the exam, equal psoriatic arthropathy. Please examine this patient with hand pain. Sometimes some other causes, how to differentiate, there is what's called Jacob's arthropathy. Jacob's arthropathy, all types of autoimmune diseases that may cause arthropathy against rheumatoid arthritis. Rheumatoid arthritis will be no reduction, or these deformities cannot be reduced, cannot be changed, fixed. Ask the patient to make a fist or to make the prayer sign, he will be not able to do it. Never to try to correct the deformity with your hand. Ask the patient to make a fist or ask the patient to make a prayer sign. If the deformity is corrected, this is Jacob's arthropathy. May be related to any other disease, like systemic lupus erythematosus, mixed connective tissue disease, dermatomyositis, any other disease, polymyopathy, whatever. So here in this group, I will share, you will find all the signs. I love to start with the hands. So here, next time, we'll start with the hands, with the nails, with the fingers, with the palm of the hand, with the dorsum of the hand, and with the wrist. And the rest, never to forget about the pulse and never to forget to examine for carpal tunnel syndrome. Carpal tunnel syndrome is a killer in the exam. In case of acromegaly, you should examine for carpal tunnel syndrome. In case of hypothyroidism, in case of any endocrinological disease, examine for carpal tunnel syndrome. In case of rheumatological diseases, case of rheumatoid arthritis, examine for carpal tunnel syndrome. So you will start with the nails, clubbing of the fingers. You should look for any signs in the nails. For any station. For any station. You should look for the nail, you should look for the fingers, you should look for the palm of the hand, you should look for the dorsum of the hand. So next time, we'll go for all the signs by systematic order, starting from the hands till the face, the hair, the eyes, the nose, the mouth, the neck, the chest, everything. So this will be a very rich session with all the manifestations of different stations of different specialties in one session. You'll never find this in any course. All the manifestation, and will be professional in identifying and eliciting signs for all stations. Because we go for example, abdominal and the chest and the cardiological. No, you should know you are a doctor. So you should, whenever you are examining the hand for a patient in your clinic, you should know what are the splinter hemorrhages, what are the Windgen lesions, or Janeway lesions. You should know ossular nodules. You should know what is the debutrans contraction, palmar erythema, clubbing of the fingers, leukonychia, asterixis, flapping tremors, fine tremors. You should know everything. So this, and then after you know whatever you examine in the hand, whatever you examine in the palm, whatever you examine in the dorsum of the hand, related to all diseases, you will be professional in any clinical examination in any station. So I will start with systematic. I will just organize all this in groups, starting from the hands, like this, and the fingers and the nails. This will be a fun in order to know all the signs and all the spot diagnosis. Spot diagnosis. These cases are spot diagnosis. This is psoriatic nails and psoriatic fingers, psoriatic arthropathy. This is what's called sausage-shaped arthropathy of psoriatic arthropathy or psoriatic arthritis. Sausage-shaped. It's dactylitis, inflammation of the whole finger. This is the blue sclera of osteogenesis imperfecta, spot diagnosis. Whenever you know this, you know medicine. So this will be, inshallah, if possible tomorrow, I will just put on the groups. But before we go, I need to know, do you think this way of learning, is it beneficial or not? This way of learning, this is different approach totally from whatever you got. So I need your feedback, please.
Yes, sir. Highly beneficial. Thank you very much for your
Thank you very
kindness.
much, Dr. Muhammad.
Yes. Agree.
Very beneficial,
Perfect.
sir.
Perfect.
Okay,
Really perfect.
thank you very much.
Thank you very much.
Thank you for all of
Very
you,
nice.
because actually this is my approach. And I think it's more beneficial than all the time discussing cases. I see all of you, you want to discuss cases and you go for scenarios and you want to practice. Before practice, go for the basic knowledge. You should know the science, you should know the differential diagnosis, you should know the spot diagnosis, you should know how to examine the patient, how to elicit signs, which most of our colleagues are failing. Eliciting signs and presenting the case to the examiner, and to know what is the investigations and the management of the case. So please leave your feedback on the group. I want to hear from you in order to encourage me to go on this way. I will not go for scenario. I will go for medicine. I am teaching you, or I'm talking medicine. Science, differential diagnosis, spot diagnosis, how to examine the patient, how to elicit signs, how to present your findings. This is the core concept in the exam. It's a clinical. So please leave your feedback on the groups, and I hope, inshallah, hear from you. If you encourage me, I will be with you daily, if this is suitable for you, and I will record and I will share recordings. So please give me your feedback. Just be generous with me. I'm generous with you. So please give me your feedback. Thank you very much, and good night. If you have any question before we go, please feel free to ask.
Dr. Ihab, thank
Yes,
you very
please.
much for the great speaker.
Yes.
I want to ask, can you tell the investigation of acromegaly?
Investigation for acromegaly. There is some investigations related to the lab investigations and radiology. For the lab investigations, we need to do first, in order to screen the insulin-like growth factor. This is the most important. And we should do the glucose tolerance test, which is very important. This is called suppression test, to give glucose, and as we do glucose tolerance test, and you examine the growth hormone. If it is suppressed less than 1, this means that this is suppressed or suppressed. This is not acromegaly. If it is not suppressed, it's called glucose suppression test. So glucose suppression test, insulin-like growth factor. And then you do all the hormones of the pituitary. All the hormones of the pituitary. What are the hormones of the pituitary? Prolactin, FSH, LH, TSH, adrenocorticotrophic hormone, and you should examine all the hormones of the pituitary gland. Then you examine for calcium. Never to forget to examine for calcium for men 1. Then to examine for targeted glands. Examine for free T4, examine for testosterone, examine for cortisol, examine for hormones related to the pituitary gland. The most important is free T4 and cortisol and testosterone. Then you examine for the basic investigation: liver function, kidney function, blood sugar. You examine for glycosylated hemoglobin to evaluate blood sugar, and you examine for renal function for any complications related to calcium or related to hypertension or diabetes. Examine the renal function and examine the inflammatory markers. Then other investigations, if you got the image that this is a case of acromegaly, go for CT pituitary fossa. CT or MRI pituitary fossa. MRI is more diagnostic than CT. So MRI pituitary fossa. You got the diagnosis, investigate for the complications. Echocardiogram, you go for colonoscopy, you go for full visual evaluation for bitemporal hemianopia, visual field and visual acuity, you go for other investigations related to complications, and the most important is colonoscopy. Carpal tunnel syndrome in case of sometimes somnography for obstructive sleep apnea. For carpal tunnel syndrome, you go for nerve conduction studies, whatever investigations needed according to the complications and associations. This is the way you think in the exam. The investigation should be related and highly related to the case. I hope this answers your question.
Sir,
Yes,
I have a
thank you.
question.
What?
Sir, I have a question. Like, in splenic infarction, is there will be splenomegaly?
In which case?
Sir, in case of sickle cell anemia.
Sickle cell anemia, there will be auto splenectomy. There will be no spleen. The spleen will not be felt clinically. There will be shrunken spleen. You will never find splenomegaly in case of sickle cell anemia. That's why they love this question, because it's a tricky question. What are the causes of chronic hemolytic anemia? What are the causes of splenomegaly? Causes of splenomegaly, all chronic hemolytic anemia, except for sickle cell anemia. There is what's called auto splenectomy.
Okay, sir. Thank you, sir.
Okay. Any other questions? Any question, please just put on the group and I will answer as soon as I can. And I hope, inshallah, we'll get benefit from these sessions, which from my point of view, this is the most helpful technique for the exam. You should go clinical, practical. You should know how to, this as a clinical exam. You should know how to examine the patient, how to deal with the patient, how to elicit signs, how to look for the important manifestations or signs in the patient, and how to present your case to the examiner. Good night, and we'll be in touch and close touch on the group. Please give me your feedback. See you, inshallah. If, inshallah, everything is okay, I will mention on the group for tomorrow. Inshallah. Thank you very much.